So first of all, just to close out this ECHO year, just to remind the Department of Mental Health and Addiction Services of the state of Ohio does sponsor early psychosis treatment programs throughout the state. So if you know of somebody who is in need, there is a website that can direct them to get care. Today, I'm going to speak on weight gain from antipsychotic medication, and I was paying attention to where everybody's from and what you all do. So it's quite interesting that there is a very diverse audience in terms of specialty and focus. So I think this is going to be interesting because certainly, regardless of whether you're practicing psychiatry or primary care, antipsychotic medications are everywhere, and the reasons for their use or their indications do seem to be broad and broadening as we go, and the problem of weight gain is well known and should be paid very close attention to, because weight gain is a very serious medical morbidity. Weight gain from antipsychotic specifically is not something that the FDA has approved medications for, although there are FDA approved medications for overweight with the FDA approvals are specifically for the condition of overweight with some complications like impaired fasting glucose or hypertension, something like that, or for frank obesity defined as BMI of more than 30. So there are FDA approved medications. I think it's important to mention because a lot of people in my field of psychiatry, we tend to not access that medical fact when we confront our patients who we are causing to gain a lot of weight. And unfortunately, the fact that second generation drugs, which were hailed as a significant advance, and to some extent that they were, the fact that they were causing a significant amount of weight gain was kind of typically of the industry downplayed massively when these drugs were introduced, and clinicians in the field were not given tremendous helpful guidance from our partners in industry as to how to prevent or restrain that problem. And just to highlight, this is in fact an extraordinarily serious problem. It is not only very stigmatizing and a source of intense bias and discrimination, it can also lead to permanent, irreversible physical damage in the form of arthritis, stretch marks, loss of blood vessel elasticity, heart disease. And if you have a heart attack, that heart tissue is dead and doesn't come back. You can also wind up with stroke and diabetes. And even if you can avoid many of those things and you simply gain a lot of weight, for many people, that is extraordinarily difficult to lose. So between difficult to reverse and frankly irreversible, the problem and its complications are to be very much respected and lethal as well. We tend not to get very alarmed by obesity because the outright lethality of obesity, I call it, death in slow motion, and the death from obesity will be ascribed in the short term to things like heart attack or other kinds of complications from diabetes, for example. But if you go back 2 or 3 steps, a significant proportion of the cause of that ultimate fatal event would be ascribed to obesity, which if you then draw one dot further up the chain could in fact be ascribed to a significant degree by the prescription of antipsychotic medications. So we should, these are things I emphasize because our partners in the industry have not, and nor has our professional society, which, by the way, I pay dues to, so I feel like I'm justified to say these things out loud. The problem, weight gain, how it happens how it happens is a little bit mysterious because it is a very multifaceted. The control of energy metabolism is spectacularly interesting and very multifaceted. And drugs, like I said yesterday when I was talking to a bunch of lawyers about psychiatric or behavioral adverse effects of medicines, once a drug is in the body, it is in the body, literally from head to toe. Anywhere there is body fluid, there is drug. We tend to have these very euphemistic and optimistic terms like selective serotonin reuptake inhibitor, and it can create this mental image of the drug going to just the right place where depression lives and tweaking just the serotonin in this place. And that's, it's a kind of a fairy tale fantasy, because to go back to, anywhere there is body fluid, there probably is drug. And even a drug that gets a name like selective serotonin reuptake, that is as well a fantasy, because most drugs are very promiscuous and they will interact with a lot of different neurotransmitter receptors, other kinds of proteins in the body. And the second generation antipsychotic drugs are particularly neurochemically promiscuous. They're kind of designed that way because these drugs were found, the magic of the second generation drugs, or the way that you can reduce psychosis and minimize the risk of neurological side effects, is to build them so that they not only block dopamine receptors, but they also block serotonin receptors. And when you do that, you inadvertently tend to block things like histamine and acetylcholine and others, and norepinephrine. So they become very dirty drugs from a pharmacological sense. And that then leads to interactions with these neurotransmitter receptor proteins in a variety of body tissues, which are directly related to energy metabolism. So it's no surprise then that a healthy human volunteer given 10 milligrams of olanzapine after 9 days of use will have a 90% rise of postprandial insulin levels. Or after 10 days of use, you'll develop insulin resistance. So the point of this slide is that the impact of these drugs with modest doses in a very short time frame is pronounced, and we should maybe consider rethinking recommendations for defaulting everybody to second generation drugs as a first choice in the treatment of psychosis, because what we're doing as a profession is saying we are going to prioritize for you, dear patient, obesity and diabetes and all its complications, which, as I said, produce their own irreversible consequences. And we're going to favor those consequences over neurological side effects, which by and large are reversible, just because we were misinformed in the late 90s and early 2000s about the advantages and disadvantages of these drugs. So there's that. This is what I just expressed as a minority opinion, to be sure, but I think it is worthy of consideration. So what should we do if we want to not give people all these problems? First is probably not prescribe these drugs if we can at all avoid prescribing these drugs, which then I would just want to show you this kind of a little bit alarming statistic of the use of second generation or atypical antipsychotic drug prescribing trends for people with bipolar disorder, a condition which by itself has had its diagnostic boundaries considerably expanded since the advent of Depakote and a whole bunch of other atypical antipsychotic drugs which got indicated for bipolar disorder. As you may know, when a drug gets approval for a condition, the partners in industry do what they call education about the disease state, which critics call disease mongering. I mean, that's the worst way to describe it, but it maybe the middle zone is sort of blurring of the diagnostic boundaries or introducing the concept of spectrum. And, many different factors have gone in, but look at this. In 1997-98, the atypical antipsychotic drugs accounted for 10% of prescriptions to people with bipolar disorders. And by the last period measured at the end of 2016, atypical antipsychotic drugs accounted for over 50% of prescriptions to people with bipolar disorder, which, if you're interested in not giving people diabetes or the complications of diabetes like heart attack and stroke, maybe is a point of concern, because lithium and Depakote and carbamazepine are perfectly useful drugs for treating bipolar disorder, don't cause nearly the amount of weight gain that atypical drugs do, and are nobody has ever shown that atypical antipsychotic drugs are more efficacious in the treatment of mania or the prevention of mania. In fact, in the prevention of mania, nothing beats lithium or Depakote so far as I know. So there you go. we can also, if we, a lot of the rise of a lot of the increasing use of atypical antipsychotic drugs these days is in fact to treat mood disorders like bipolar disorder or treatment-resistant depression. And to be fair, the atypical antipsychotic drugs, some of them, are quite useful tools in the treatment of treatment-resistant depression. However, I spent about a decade focusing largely on treatment-resistant or complicated depression cases, and this statistic is very aligned with my clinical experience. A massive proportion of people that don't respond to 1 or 2 or 3 or 4 or 5 attempts of antidepressant medication turn out to have very significant habits of thinking or environmental social stressors or personality factors which would be unhealthy or frankly would be diagnosable as personality disorder, which never get recognized and certainly don't get adequately treated. Also, since I'm a little bit ranting, in all the patients that I would receive, what's it, 90% of the patients that I would receive that had never had response to antidepressant medications, basically the only treatment they ever got was antidepressant medication. And I would ask, they would all say that they had therapy, and I would ask them, they all said that they would love the therapist as well, and they would talk with the therapist for many years on a regular basis. And I would say, so great, in all your work with your therapist, what is your understanding from your talks with your therapist about what are the psychological factors which are causing your mood to be depressed, and what are you doing in therapy to address those psychological factors? And almost every one of those 90% of my patients had no idea what I was talking about. So most of them seemed to be describing supportive listening, which they were getting. So, but by the time they saw me, you can be sure that they were all on Seroquel or Zyprexa or a host of antipsychotic drugs and had gained a lot of weight. So we can look for evidence-based alternatives, as well. Brain stimulation like transcranial magnetic stimulation or ECT are really effective treatments that involve zero weight gain risk. To be fair, they have their other risks, but weight gain certainly is not one of them. If we want to also minimize the risk of weight gain, we can choose very carefully which medicines we want to start people on, and we can avoid medicines with higher weight gain risk. Lots of people have looked at weight gain risk and come up with rank order of risk estimations. Different analyses come up with somewhat different orders, but drugs like ziprasidone or haloperidol or fluphenazine and aripiprazole or acetone and cariprazine, they do come out toward the low end fairly consistently. Drugs that are, and these drugs, roughly and simplistically speaking, tend to have a narrower range of pharmacodynamic actions. They knock on smaller numbers of neurotransmitter doors. And drugs that are dirtier or that have more numerous neurotransmitter actions, and particularly the ones that are stronger at blocking serotonin receptors and or stronger at blocking histamine receptors. And these will be drugs that are also tend to be more sedating. Those are the drugs that tend to have much higher weight gain risk. A lot of my colleagues in inpatient psychiatry these days, under the influence of management, which is under the influence of insurance, are driven to do length of stay, which is entirely divorced from any form of reality or evidence. And so they're actually driven to practice sedation psychiatry. So sedating drugs are extraordinarily popular. So lots of people are started on olanzapine or Seroquel simply because they want to get people sleeping and sedated. And by and large, and any drug will work for that. I mean, any drug, they may get some benefit, and then nobody wants to change anything that has even a chance of working. So then a lot of people, simply driven by the need to produce quote unquote stability, which is not a medically defined term, but driven by insurance and short length of stay. Again, I'm ranting, I know, but the point is, these are factors which are driving the prescription of drugs that have massive weight gain risk, which, if not interrupted, will lead to large numbers of people developing a lot of excess weight, and that will shorten their lifespan. So this is literally a public health crisis, which in many respects is being driven by insurance considerations for short length of stay and chasing this goal, again, not a medical goal of stability. So you can do that. You can also then, let's talk about, so basically there are more slides that say, choose a drug with lower risk if you want to, if you have to use an antipsychotic drug, and minimizing weight gain is an important goal. Then you have that option. If you want to, minimize the risk of weight gain further, or try to reverse weight gain that has occurred, or slow the pace of weight gain, then every clinician on the planet says you should eat less and work more. They practice thermodynamics, which theoretically is very good. And if you look to published research studies, you'll find no shortage of them that say that it works. But keep this in mind, please, dear colleague, that every research study that shows that diet and exercise works will select only people that are able to make informed consent to be in such a study and are interested in being in such a study. So there is a fairly significant selection bias at play in all those studies that say that it's helpful. It might not represent real world conditions. Secondly, you're more or less asking people to starve themselves a little bit or a lot, and that the body tries to fight back just because the body craves, homeostasis. And consider this, that, many of my friends who don't have any kind of mental illness and a lot of really high level cognition benefits and a lot of money, and can hire personal trainers, and can have food shipped into them and all these really luxuries, they fail routinely at diet and exercise programs. So well-resourced people without the burdens of mental illness, cognitive impairment, and drugs prescribed by their doctors which stimulate appetite and impair their insulin response. So in other words, drive the factors that drive weight gain, they fail. So when we as physicians tell our patients to whom we're giving appetite stimulating and metabolism altered drugs, when we tell them eat less and exercise more, I want you to be impressed with the fact that that might be a just outright impossible task. In fact, some people have shown it just simply fails. In this study done in a hospital, in a locked ward, where people were given pre-measured food to 1,800 calories a day, encouraged to exercise with equipment on site, people gained weight. So, there may be something. I tell medical students, if you want to get a Nobel Prize to your students seriously, do consider what's going on with this, because the most effective drugs for schizophrenia are the drugs that cause the most weight gain. And we've known for 100 years that people who get schizophrenia have family histories which are enriched in type 2 diabetes. And Krepelin in 1920 was citing studies that showed people with dementia precox, as he called it, had lower oxygen consumption than people otherwise. So there is energy metabolism abnormality seems interwoven with at least some forms of schizophrenia like psychosis in a way that, if we understand, I think will be quite revolutionary. So there's that. There's your locked ward, pre-measured food with exercise equipment on site intervention. It completely not effective. They gained weight over 90 days of time. Curious ketogenic diet is very popular these days. It's a very low carbohydrate diet, which stimulates the metabolism of fat, which generates ketone bodies. And way back when, I left the state hospital one day, and for some reason I was thinking about all the anticonvulsant drugs I was prescribing, and then I remembered some piece of medical school knowledge that 100 years ago they were using ketogenic diet to treat epilepsy, and I was wondering if an anticonvulsant diet might have similar effects to a drug like Depakote in psychiatric patients. So I went home to my computer and started to do a bunch of research, and was quite surprised that there was a study in Sweden that showed in, I think it was women with schizophrenia, there seemed to be a benefit of a ketogenic diet, and several case reports describing both weight loss in people that had gained weight and wanted to just stop eating carbs. And in one of the case reports, it was the woman herself who just got the idea to not eat anything that had carbs in it. She ate tomatoes and burgers and tomatoes and meat, and I can't remember her diet, but it was just very ketogenic. And she had basically had hallucinations for decades nonstop, and she lost a significant weight, and her decades-long hallucinations went away entirely. So it may be a thing. And one of the advantages of ketogenic diet, many people who do it find that they can run caloric deficits without stimulating hunger. And so it might be a thing, but despite the promise of it, I've seen so far no studies, organized studies, to see whether it does anything, to prove whether it works or not. So a lot of hints of a success, but no real proof of it yet. And so and then I'm trying to go through quickly so we can have some more time for discussion. And I guess you can access slides from Jamie if you want to get a copy of them. But just one thing that I periodically go back to the ketogenic literature just to see what new psychiatric applications might be found from it. And this was a interesting and very unexpected finding, where they described somebody who had anorexia, who managed to normalize her eating behavior, but still had a lot of psychological distress. And to the, I guess, credit and somewhat boldness of thinking of her doctor and her treatment team, they put her on a ketogenic diet with the rationale along the lines of maybe in anorexia, there is maybe the ketogenic component of anorexia creates a kind of positive mood state that drives the anorexic behavior. So that is approximately the rationale. And so they sought to deliberately create a ketogenic state with keeping the calorie balance so that she wasn't going to lose weight or go into unhealthy eating. And that it was really an impressive report. I don't know that I would be, I await replication, but it could be really quite fascinating to see if that pans out in a real study. Metformin, to the primary care folks in this audience, you undoubtedly know this medication. You probably know that it's a medication which has a very good safety profile. It's been around for decades. And if you have healthy kidneys or generally good health, it is something that can be used with for a drug, relatively little concern. It does a lot of things for people with type 2 diabetes. In people without diabetes, such as, for example, women of perimenopausal age who are simply overweight or obese, again, without diabetes, metformin assists with weight loss. And, oh yeah, there's a slide that shows that with a reference. And in 18 randomized controlled trials in people with antipsychotic-related weight gain, comprising 1,200 subjects, overall, in this meta-analysis, estimated effect size 0.7. That's a pretty healthy number of individual studies. It would be nice if they were, systematically done. But of all the studies that exist, the data from metformin is pretty good. And it saddens me that an organization like the American Psychiatric Association or somebody hasn't just come out and recommended to all clinicians, like to all psychiatry trainees, for example, learn how to prescribe metformin, just like you learn how to prescribe Cogentin, because anybody who gives medicine to cause weight gain should probably learn to prescribe medicine that can mitigate weight gain. And metformin, in terms of cost, $4 a month, length of existence in the marketplace, knowledge about efficacy and side effect, I think, in my way of thinking, looks like a first-line treatment to me. Interestingly, tiny amount of data, but intriguing, suggests that it may also mitigate the risk of hyperprolactinemia. approved, speaking of drugs that have FDA approval for overweight with medical comorbidity or for obesity, are GLP-1 agonists. Originally developed for type 2 diabetes, these drugs mimic the action of glucagon-like peptide type 1. They change glucose absorption. They help the body to produce insulin when needed, and they have this very interesting effects on satiety that overall leads to make it easy for people to lose weight who need to lose weight. I understand now there are shortages on these drugs because they've been prescribed for Hollywood types who want to, they're being used kind of cosmetically, but they are, that is a bit of a testimony to their, I guess, their efficacy and their relative ease of use, although I think metformin has a better side effect profile, but maybe less less effect size. The GLP-1s are, there's fewer studies, newer drug, fewer studies. Overall, the data are looking like they're effective for GLP-1. I've personally been part of the care of a handful of patients that have gained significant amounts of weight from clozapine and have lost 50 pounds while on GLP-1 agonists from clozapine. So, my clinical experience is aligned with the limited amount of published data to say that they can help people lose weight with a high degree of, with a large effect size. And they're on label. Problem is they're very expensive, and insurance is going to probably find every way possible to not pay for it. The handful of patients that I've had that have gotten on it have had, in one case was a family of means that paid for out of pocket, and another case, a family that had like exceptional insurance that got it paid for. But it will be a struggle. But I think if anybody wanted to get really active and stuff, I think that probably insurers ought to cover this, because it'd be nice to be able to get well from schizophrenia and not, die 10 years early from obesity complications. Topiramate is interesting drug. It is less well known. It's a fairly common side effect that it causes anorexia. Nobody understands exactly how that happens, but it does. And there have been a number of studies on that, not quite as many as for metformin, but a fair amount of studies. And I don't have an effect size number, but average reduction of 4 kilograms, significant. And not here, but there are other meta-analyses of topiramate and schizophrenia, which show on average an ability of topiramate to improve symptoms of psychosis and other general psychiatric symptoms in patients with schizophrenia. Having said that, there are people with schizophrenia who have worsening of psychosis with topiramate. So if one chooses topiramate, monitor carefully, because there are people who get worse, and most clinicians are aware of the risk of cognitive slowing or that kind of side effect. But it seems that overall statistical average favors a weight loss side effect, and overall statistical average favors an overall improvement of global mental status with topiramate. Relatively cheap, relatively long period of clinical use, and most psychiatrists are relatively comfortable with prescribing that. Probably nobody knows about prohistamine drugs, but there are some histamine-based approaches. The sedating action of antipsychotic drugs is due to H1 histamine blocking. H1 is also an appetite signal, and blocking histamine or blocking the H1 receptor stimulates appetite. Probably also has something to do with changing metabolic balance toward weight gain. Suffice it to say, H1 blocking drugs are associated with weight gain. Now it gets really complicated. I'm not going to go into all the details, but there are families of drugs, H3 antagonists presynaptically. They are prohistamine drugs. So instead of being antihistamine, they're prohistamine in their action. And if antihistamine promote sedation and weight gain, then prohistamine promote alertness and weight loss, is the simplistic way of saying it. Pitolisant is I haven't priced it. It's probably ridiculously expensive. It's an approved branded only medicine in class in the US, approved for excessive daytime sleepiness in adults with narcolepsy. But there is a case report of somebody who gained a lot of weight with olanzapine and on pitolisant was found to lose weight and have improved cognition and reduced negative symptoms. So there's that. I don't think that that's probably, because of cost, realistic for anybody. But there is a drug also very curious in regulatory status called beta histine, also H3 antagonist. So basically the same pharmacodynamic action as pitolisant, but way cheaper. Curious regulatory status. It's available in the US, although it's not approved by the FDA for anything. So it's basically an unregulated drug, although you can get a compounding pharmacy to make pills for a patient. People with vertigo, with Meniere's disease, are doing that even today. In fact, I called a compounding pharmacy like 5 months ago to see if this is really true, and they can do it. So if I had a patient that I wanted to prescribe beta histine for, I could arrange that through like Walgreens compounding pharmacy or any other compounding pharmacy. And there are more reports of successful use of beta histine to do like what the case report for pitolisant did, promote alertness, improve cognition, and reduce weight gain associated with antipsychotic drugs. So really small amount of data, and with a smaller amount of data, you can't really say high levels of confidence whether it's highly safe or not, although lots of Meniere's patients are taking it. So it seems relatively-ish sort of safe and represents an interesting option for people to consider. Then anti-opioids, there's a drug that Lilly has made, what is it called? Lybalvi, and it's a combination of olanzapine with samidorphan. Samidorphan is kind of like naltrexone. It's a opiate receptor antagonist. The theory is kind of interesting because the theory is that that the opioid system is a reward system and food is rewarding. So if we block the rewarding signal of food, then maybe people don't eat so much. So it's a nice theory, but it sort of says that weight gain from antipsychotic drugs is similar to alcoholism. And I've never seen, up until when Lilly comes out with this drug, nobody's ever suggested that antipsychotic induced weight gain happens because antipsychotic drugs are making food more palatable. So so there's that. The studies that Lilly cites that Lilly submitted to the FDA showed weight loss or mitigation of weight gain in people treated with it. Although a meta-analysis, including studies that weren't submitted to FDA, shows overall no significant effect on weight. And so there's the grain of salt to the overall data. And I would submit that it's maybe not so important, the number on the scale, as whether you're protecting insulin sensitivity or glucose levels or triglycerides. And there's, naltrexone probably it's not set up to have a really strong interaction with insulin sensitivity, glucose levels, or triglycerides. And indeed, if you look at those measures of metabolic health, there's not a big signal for benefit. So you might maybe optimistically reduce the pace of weight gain, but so far as the published data would suggest, there's not a really strong protective effect on the things that would ultimately shorten your life. So obviously I'm not a fan of Lybalvi at the moment, but there's that. I have a love-hate relationship with olanzapine because I think it's a really useful drug. It does a lot of, it can be very fabulously helpful. I know people who take Zyprexa, get great benefits and want to stay on it despite gaining a lot of weight. So I think it has a lot of benefit, but it certainly does have a weight gain risk. I wish that naltrexone would be better than, or that samidorphan or naltrexone would work better than it did in Lybalvi. So I don't think that the opiate system is the way to solve the weight gain problem for Zyprexa. I think that, sorry about this. I would say if one wants to use Zyprexa, and there could be very good reasons to use Zyprexa, then Zyprexa plus metformin, or Zyprexa plus GLP-1 agonist, or Zyprexa plus beta-histine looks like a much better approach, because that has a better chance of counteracting the things that Zyprexa does.